Good morning, everyone. Thank you for the presentation, professors. So my task here is to talk about detection of early upper GI cancer and treatment of early upper GI cancer. So as you know, the diagnosis of early cancer of the GI tract relies on our hands. And are we doing a good job? The blunt answer is no, we are not going to do a good job. As we may see, several papers, systematic reviews, showing that patients with advanced esophageal and gastric cancers, at least 10% of them had EGD, normal EGD, 1 year and 3 years before the diagnosis of advanced cancer. Another systematic review showing the same figure. So we can swipe the dirt under the carpet, or we can improve our endoscopic technique. In this sense, I invite you to read this important paper by Professor Kenshi Yao from Fukuoka University, and he explains us the endoscopic diagnosis of early gastric cancer. And Professor Yao, he focused on the technique and knowledge to detect early lesions of the GI tract. So concerning preparation in Japan, they use a proteolytic substance called pronase that we don't have in Brazil. But in Brazil, we have simeticone and N-acetylcysteine that improves the endoscopic view of mucosal surface. So there are some papers showing that, yes, with N-acetylcysteine, you can improve the gastric mucosa visualization. And it's our practice to offer the patient a mixture of 100 cc of water mixed with simeticone and N-acetylcysteine 20 minutes before the endoscopic examination. And by doing this, we improve gastric mucosa visualization and permits detection of early gastric lesions, as we may see in here. And this simple act was proved in a randomized controlled trial to improve the endoscopic visualization of gastric mucosa, and it was published last year in Gastrointestinal Endoscopy. It's our practice also to use scopolamine, buscopan to reduce the peristalsis and improve diagnostic accuracy. At least it reduced the inspection time for sure. You should be aware that causes some tachycardia, so we should use it with caution in patients with cardiac conditions. Adequate insufflation is key for the detection of early lesions, as you may see in the example. The suboptimal insufflation, and here we can see very clear early gastric lesion with adequate insufflation. It's very important to perform a systematic procedure. So the Japanese taught us that we need to take at least 22 pictures of different positions of the stomach to be sure that we have seen all the gastric surface. And recently, a multi-center panel published in Digestive Endoscopy this special report simplifying the way to perform upper GI endoscopy, and this paper was sponsored by WHO, so I invite you to read this paper on how to systematically examine the upper GI tract by endoscopy. And for this systematic evaluation, you need to allocate adequate time. I know that time is money, but I invite you to read some papers, such as this one, showing that endoscopists who spend more than 1 minute for every centimeter of Barrett's had a higher suspicious lesion and high-grade and carcinoma detection rates. So if you allocate more time just inspecting the mucosal surface, you're going to increase your neoplasia detection rates. This is for Barrett's, but there are also studies showing the same results for early gastric cancer, such as this one. They compared the fast versus slow endoscopies with a cutoff of 7 minutes. Once again, slow operators had a 3-fold increase in the detection rate of cancer in dysplasia in the stomach. Another paper showing the same results with a higher number of patients. You see that the moderate and slow operators who spend more than 5 minutes inspecting the stomach had a 2-fold increase in the detection rate of early cancer in the stomach. And this large trial with more than 100,000 patients published in Gastroenterology a couple of years ago showed the same results. A fast and a slow endoscopist with a cutoff of 3 minutes had a higher chance of detect neoplasias in the upper GI tract. So that's why this paper teaches that we should expend at least 8 minutes for a gastroscopy, 2 minutes to have adequate intubation, clinic, to reach the second part of duodenum, 4 minutes for a good inspection of the gastric mucosa, and 2 minutes for the esophagus, including 1 minute for every centimeter of Barrett's esophagus, and focusing on 3 o'clock position because this is the spot where we find more frequently cancer or dysplasia in Barrett's esophagus. So I would add that preparation, sedation, peristaltic and systematic procedure, I would add 8 minutes allocated for a good upper GI endoscopy. And be aware that several societies now are issuing their protocols of quality indicators in upper GI, including all these aspects that I just mentioned to you. So about characterization, how to improve our rate of detection of early cancer of the upper GI tract. So most of us, we have access to white light high definition endoscopy and chromendoscopy, and magnification is also very important. I want to mention about artificial intelligence. I think it is going to be mentioned by other speakers. So concerning Barrett's esophagus, with white light high definition endoscopy, it's somewhat easy to detect this redness here, this red area compared to this one, and here is suspicious for grade dysplasia. If you put some zoom and NBI, you can see the distorted vessels, and this is very suspicious for high-grade dysplasia or even early cancer. There is some systematic reviews showing that by using NBI or any technique of electronic chromendoscopy, you increase the dysplasia and early cancer detection rate, or at least you reduce the number of biopsies that you need to detect high-grade dysplasia and early cancer. Another way to improve the high-grade dysplasia detection rate and cancer detection rates is to use acetic acid solution. When we spray acetic acid solution in Barrett's esophagus, you have this nice aceto-whitening reaction. And it's interesting that the spots where you have high-grade dysplasia, this reaction disappears fastly, as you see here. So you see the aceto-whitening reaction here, and this is very suspicious for high-grade dysplasia or cancer because it has disappeared earlier than the other areas. And this was proved to be high sensitivity and specificity for the detection of high-grade dysplasia. Concerning esophageal squamous cell carcinoma, when you perform white light high-definition endoscopy, we should look for these flat discoloration areas, as you may see here. And then we use NBI or electronic chromendoscopy, and you see a higher density, vascular density in this area. We spray Lugol solution, and when we use Lugol solution, at first we have a discolored area, and 2-3 minutes later, you have this pinkish aspect. This is called the pink sign color, which is very specific for the detection of high-grade dysplasia or cancer. You see here the patients who had a pink color sign, positive sign, they had high-grade dysplasia, invasive cancer, or low-grade dysplasia. But remember that the presence of pink color sign is not sensitive, it is specific. If present, you can tell this is cancer. If not present, you cannot be sure that it is not cancer. Another hint for detection of early cancer, squamous cell cancer, is the irregularity of the mucosa with these pearl drops. This is very characteristic of early squamous cancer. And you apply NBI, you see high vascular density in this area, followed by Lugol solution, and you can detect cancer. But should we use Lugol for all patients that we do upper GI endoscopy? I think that the patients, some groups of patients need to be screened, and are the patients with alcohol and tobacco abuse, alcoholic cirrhosis, and mainly patients with head and neck and cancer. Patients with head and neck cancer, they have high risk of a secondary tumor in the esophagus, from 5 to 12%. So this is our experience in a small cohort of 129 patients with head and neck cancer. We found 7% of them with squamous cell cancer. And even patients with achalasia are at risk for esophageal squamous cell cancer. In our experience, we have found this situation in 2% of them. And this is our experience in the Institute of Cancer of São Paulo. over there we screen systematically all patients with head and neck cancer. So over 7 years we have screened 2,200 patients for esophageal squamous cell cancer using NBI and Lugol in a systematic way. And by doing this, in the last 7 years, we have found 121 squamous cell cancer in the esophagus with a 5.5% of frequency in this group of patients. And remember, if we just used white light endoscopy, we would have missed 60% of the lesions. So we need to use Lugol or chrome endoscopy to detect early squamous cell carcinoma in the esophagus, and this is our experience. Concerning gastric adenocarcinoma, once again, Professor Kenshi Yao taught us that to differentiate small flat cancers from focal gastritis, we will need NBI associated with magnification. And he described the signs of cancer, the presence of a demarcation line. You see this flat lesion here, you put some zoom, magnification, and NBI, you see normal tissue and abnormal tissue, you see a very clear demarcation line. Another sign of cancer, the vascular and the surface patterns. So you have to look this under magnification and NBI. And in a very, very easy way, if you have the presence of demarcation line and irregular vessels, this is cancer. So you have this flat lesion here, you magnify, you put NBI, and you see demarcation line and irregular vessels. This is cancer. If you find only demarcation line or only regular vessels, so maybe this is not cancer, maybe this is only inflammation. But the association of both is very characteristic of cancer. And I'm gonna end my presentation on how we organized an ESCD program at the Institute of Cancer. First, you must have a very robust detection and staging program of superficial GI cancer. It's very important to submit all the findings to a multidisciplinary board to review all the cases and to offer the patient the best management. Then, when you perform ESCD, there are some quality indicators to assure that you are providing the patient high-quality endoscopic submucosal dissection. So once again, I show you, we have this screen program of head and neck cancer patients. We submit them annually to high white light, high definition endoscopy, plus NBI and Lugol. So more than 2,000 patients. We found 121 esophageal cancers, most of them, 90% early lesions restricted to the mucosa and maximum submucosa. Most of the patients were male patients, and all of them with head and neck cancer. And we select the good cases for ESCD by the Paris classification, by magnification, and EUS in some cases. We know that Paris classification 02B and 02C, usually these lesions are restricted to the superficial mucosa. So these are the good lesions for endoscopic resection. And we also use magnification as described by Professor Inoue, and this classification is simplified by the Japanese Esophageal Society, and we know that lesions that present these large tortuous vessels called B3, probably they have invaded deeply in the submucosa. So we select Paris classification 02B, 2C lesions, and lesions who has B1, B2 IPCL pattern. So these are the good lesions for ESD. And when the lesion has an unclear or 02A pattern on Paris classification, we do both magnification and EUS. So let me show this case. It's difficult to tell the Paris classification here. Here it seems a little bit depressed, but there is some retraction, some fibrin here, so it's difficult to tell. Under NBI, you see the lesion, and the Lugol, a negative Lugol lesion, probably squamous cell carcinoma. Now you can appreciate the pink color sign. You see negative Lugol, and here pink color sign, very evocative of squamous cell cancer. EUS, this is the submucosal layer, seems to be intact. The Muscular propria layer seems to be intact too. I don't see any lymph nodes around the lesion. And this is the magnification. This is B1 vessel, and this is B2 vessel. But I don't see B3 vessel. So this is a good case for ESD. So we performed ESD in this case, and it was a well-differentiated squamous cell cancer restricted to the muscularis mucosa, M3, and, we obtained curative resection by ESD in this case. So it's important to keep track of the results when you have an ESD program. So this is what I'm showing you, the characteristics of the patient submitted to ESD, the characteristics of the resections, and the most important outcomes that you should focus are unblocked resection rate and curative resection rate. So you should have an unblocked resection rate of very high, above 90%, and a curative resection rate above 80%. So this is very important to keep track of these findings. So in conclusion, ladies and gentlemen, Mr. Chairman, I think that for a good detection of early upper GI cancer, you need to offer adequate preparation and allocate adequate time for a good upper GI endoscopy. It's mandatory now to use chroma endoscopy, NBI or equivalent plus acetic acid for Barrett's esophagus, NBI or equivalent plus Lugol for squamous cell cancer of the esophagus, and NBI and magnification for gastric adenocarcinoma. Concerning the treatment of early upper GI cancer, I think that we should offer the patients a robust screening and surveillance program for the patients who are at high risk for the disease, and all the findings should be submitted to a multidisciplinary tumor board. We should offer accurate staging and high-quality ESD. And I'm looking forward to welcoming you in Rio de Janeiro for the World Congress of Endoscopy. Thank you very much.